Hi, my name is Rohan and I'm doing an exploration with my partner about the Lubbock community's experience during the COVID-19 pandemic. If it's all right, I was wondering if I could ask you a few questions regarding your experiences and views regarding the pandemic.
Absolutely.
So to start off, if you could state your name, profession, and the number of years in your profession.
Okay. My name is Trey Morris, and I'm an emergency physician, and I've been practicing for about 19 years.
Thank you. If you could explain your background or experience in the Lubbock community, professional or otherwise, just a little backdrop.
I am from West Texas. I attended medical school at Texas Tech between 1999 and 2003. Prior to going to residency at Baylor Scott & White in Temple. I returned in 2015 and since then have become the program director of our emergency medicine residency program here. So I've worked in academic and community hospitals for my entire career.
So you had quite a while in the West Texas community.
Yes.
Last while. So to start off, our first question is if you could give us a little bit of background and on your personal experiences working as a health professional during the COVID-19 pandemic as compared to before the pandemic.
Sure. I think that the most notable aspect of it was during April of 2020, late March and April of 2020, the ER really was a ghost town. I've never seen people afraid to go to the ER to the same extent that they were. The only people that were coming in were those that were very sick and dying of COVID, and then a few scattered MDCs and heart attacks. One of the concerns that epidemiologists have had is that many of the COVID deaths may have been undercounted, and people were perhaps labeled as other causes of death, and that we really have no way other than looking at excess deaths in comparison to previous years, how many people stayed at home and died of heart attacks or strokes or maybe had a perforated appendicitis because they were afraid to seek care for fear of catching COVID. That's one of the things. I don't know if all of the data is in on that, but that's certainly one of the concerns we had, is that we get used to a certain background level of emergencies. In a city the size of Lubbock, we expect X number of people to have a heart attack every day and a Y number of people to need surgery. And during the peak of during the initial peak of the COVID pandemic, we just weren't seeing those patients. Surprisingly, I think as COVID became more politicized, we did not see the hesitance to seek care in the later Delta and Omicron surges.
So would you say that, you said that in April or March of 2020 the ER was deserted because people were afraid of coming in. Would you say that like before the pandemic set in there was a lot more kind of non-emergent people according to like quantity that would come in as compared to the beginning of the pandemic?
Sure, I would say that at the beginning of the pandemic, the people that came to the ER were almost uniformly very, very sick. It's difficult sometimes to sort out non-emergent complaints. Most of the reasons that people come to the ER, even if they wind up being ultimately determined to be non-life-threatening, it's not reasonable to expect a layperson to know that. For instance, costochondritis, reflux, shingles, these are all things that can cause chest pain. And it's not reasonable to expect a layperson to be able to distinguish those from aortic dissection and pneumothorax and coronary artery disease. And so whenever you hear that the ER is full of non-emergent complaints, to some degree, looking at discharge diagnoses is misleading. And I think a better measure is to look at what the chief complaint of the people that presented was.
Give me just a second to write this down.
Of course. But that being said, the people that did come during the initial COVID peak were very, very ill.
So for our next question, how do you feel the Lubbock Health Administration responded to the COVID-19 crisis? And on that same note, what do you feel are kind of some of the weaknesses and the strengths, or maybe something that the Lubbock health system did better in regards to the pandemic as compared to worse?
So I think all in all, given the uncertainty and the sort of moving target nature of COVID-19, I feel that the healthcare community and leadership in Lubbock Texas actually did a very good job. Our public health authorities were out giving people sound advice. Our hospitals and their leadership prioritized urgent care for the pandemic, but also tried to make sure that we were not forsaking the people who didn't have COVID. Because as mentioned, there's a certain background level of emergencies that happen in a city the size of Lubbock. And I think our administration actually did a really pretty good job of trying to balance maintaining access to care for citizens even without COVID. I think that the infusion center that was set up in the Old Grace Hospital by the Lubbock Health community was a tremendous asset. I think that especially early on in the pandemic, testing was paramount. And I think that the efforts of the hospitals and the public health community to have access to safe, effective, efficient testing was tremendously impressive. If you think about all the moving pieces that goes into something like setting up a drive-through testing site, it's really impressive that we were able to test as many people in as short a time period as we were. And so I do think that the local health community deserves kudos for that. Some of the things that we could have done better. This is more of a long-standing issue, but I think that the COVID-19 pandemic really drew attention to the fact that if we do not have a safety net for our citizens in rural areas, that's going to impact people in the cities as well. Many times when it comes to healthcare, it's easy to think of people in rural areas as just sort of that what happens there doesn't necessarily impact people in the cities.
Kind of disconnected.
That it's that it's maybe inconsequential, but we found out that as rural healthcare systems became overwhelmed and they didn't have the capabilities or resources to take care of their COVID patients, those patients got sent to our ICUs, which means that our patients stayed in the ER, and which meant that other hospitals that wanted to send patients to our ICUs didn't have that option. And there were numerous stories of people being sent, states and entire time zones away.
Wow.
Because that was the only ICU available. And so if our healthcare leaders and policy leaders are paying attention, they'll use that opportunity. They'll take that as a wake-up call to reinforce our rural healthcare. There's a large portion of the population that sort of fits into that category. Lubbock actually has, having practiced in various different cities, Lubbock has a very good, very robust program called the LCMI, Lubbock County Medically Indigent Program, that provides access to care through Texas Tech, EMC, for patients who are unable to afford health care. But there's still a gap between those patients and those who are able to afford health insurance. And I think that population in particular was very hard hit. And I don't know that we've necessarily made significant strides to correcting that.
So they kind of fit into that middle area where there's other people that can pay for healthcare and insurance of their own. So for our next question, what community response or opinions did you observe regarding the COVID-19 pandemic, kind of like within the population? I know you spoke a little bit on it earlier, where some people were thinking that it wasn't really that big of a problem, or if there wasn't need for a vaccine or need to follow rules and regulations. So if you could speak a little more on what you observed in patients regarding that, and if there were any factors that you think kind of contributed to these opinions.
Sure. One of the most surprising things, I think, during the COVID pandemic has been people coming in obviously very, very sick from the illness, yet who deny that they have the illness, who, people literally with their dying breaths saying, "Don't give me that vaccine." And it's surprising because at least in my lifetime, I've not seen, since HIV, a health condition be this politicized. With HIV, especially in the 80s, it was thought that only very select groups could acquire the disease, and that it was someone else's problem. With COVID-19, the fact that it had such a wide variety of presentations, I think, allowed people to minimize it, because we know, in fact, there are many people who were infected who were asymptomatic, and I think that that coupled with the misunderstanding of statistics, allowed people to underestimate the threat that it posed to our healthcare system. That I think was the most surprising. I do think that long term, I'll say that by and large, our society is probably not great at understanding science. That there's a large element of our society that prefers to think in absolutes, and that doesn't understand the sometimes tenuous, halting, and self-correcting nature of science. And so when there was a PPE shortage and public health officials were telling people not to wear masks, essentially what they were saying was don't go out and buy up all the masks,
right,
because we need those for our healthcare professionals. But people heard that as masks don't work. And then later on, when PPE supplies were stabilized and universal mask usage was encouraged, people took that initial advice as a way to undermine the importance of wearing masks. And I think there's so many people talking about how viruses are so small they'll fit through the particles, and ignoring the fact that yes, but most viruses are carried on droplets, and so if you can stop the droplets from spreading, you're going to stop a great deal of the viruses. I think that there was a lot of, thanks to media and social media, a lot of self-reinforcement of alternative information other than what was coming from the CDC or the sort of our recognized public health officials, and that contributed certainly to the prolongation and the duration of the pandemic.
So do you think that something that might help this issue is kind of like an increase in education, especially for like disease spread, or kind of more education on what exactly a virus is and how it would infect people?
That's a tough question. I think at some point in one of your social determinants of health classes, you'll hear about people being in the pre-contemplation stage of quitting smoking, for instance. And I don't think it's that anyone really is trying to convince themselves that smoking is good for them. It's just that there has to be a certain readiness to accept information. And I don't know that for much of our population, I don't know that they're in that state. And I don't think it's as simple a matter as education. I think some of it is restoring trust in public health authorities, restoring trust in the media, and restoring, honestly, trust in expertise. We've reached the stage where someone's web search, they feel that supplants an immunologist PhD. And when that's the case, it's applying additional information is probably not going to be effective. And so I don't know what the answer is, but unfortunately, I don't think that just educating people on viruses and droplet spread and things like that, I don't know if that's going to be effective, because I believe for many, many people, their mind is already made up.
So for our next question, what long-term effects do you think that the pandemic will have on the community maybe 5-10 years from now, kind of from a health or social or even economic standpoint? And I know there's probably some short-term effects that we can already see, but if you had any thoughts on that?
So the long-term effects from a health standpoint, I think the most honest answer to that is that we don't know. We know a certain percentage of people who experienced COVID have long COVID. Maybe even some of those people were asymptomatic initially, and so it's very difficult to get a hold of the numbers. And to be honest, we know that there are viruses and other infections that lay dormant for years, even decades, and then have some sort of recrudescence that leads to symptoms. And I think that we probably will see something similar with COVID, but we don't know to what extent. I think that it would not surprise me if we saw more people with chronic lung disease down the line. Not just COPD, but maybe pulmonary fibrosis and other interstitial lung diseases. From a social standpoint, as I kind of alluded to earlier, I think that this really called into question where we obtain our information from, what sources we consider to be reliable, and what we do with that information. It's easy as a healthcare worker to imagine that people are eating, breathing, sleeping COVID every day because that's what we were doing. And then you forget that a lot of people, this was just sort of a tangential concern, and especially if they were inclined to minimize its impact or believe that it was overblown anyway. And so it's hard to put myself in the shoes of someone that didn't experience what I did as a provider in the middle of the pandemic. But I do think that it's the net effect has probably not been beneficial to our institutions and to trust in our government, our experts. And the third phase was
from an economic standpoint.
From an economic standpoint, I think that it really opened the eyes of a lot of people to why are we doing what we're doing? Why are we killing ourselves for a minimum wage that hasn't changed in decades? And I think it has shifted the balance from employer to employee or job seeker. I think we're seeing that a lot of people realize that it's not worth the risk of working with the public. It's not worth the exposure. It's not worth the sometimes unacceptable conditions that they were working in. And so I think it's made people a lot more willing to quit jobs or to not take jobs. And I think that's probably going to wind up being good. The combination of increased demand and a somewhat decreased supply is, I think, can only benefit the job seekers. And I think so much of health has so little to do with medicine.
Right.
And so I think that as we have improved living conditions and better access to people that can afford prescriptions, people that can afford insurance, etc., I think that's going to wind up having long-term beneficial impacts.
So it kind of puts some pressure on employers and to kind of make sure that the employees are satisfactory.
Yes, that their employees are taken care of. That they especially certain industries hit harder. I think the food service industry has been hit particularly hard. Right. Every place you drive around town, every restaurant has now hiring help wanted signs, etc. And those are often some of the lowest paid jobs in society. Right. So I think that being forced to compete for workers by improving wages, improving working conditions will be beneficial for the employees. I think that's going to have some long-term effects. I think the pandemic may have done something that the job market has been out of whack for a long time. I think real wage growth has been flat for a very long time, and I think partly because of excess mortality, partly because of some increased morbidity, and partly because of people realizing that we can shut things down and they can quit their job and find alternative options. People are less afraid, and we will get more mobility in the employment markets.
So going from there, we noticed from our secondary data assessment of Lubbock that almost 20% of the population here has no insurance or very little insurance that covers or doesn't cover a lot of health treatments or outcomes. So how do you think this played into the effect that COVID had? I know initially you said that when the ER was deserted and only the really sick were coming in. How do you think kind of this large percentage of uninsured patients kind of played into either patients not getting the treatment they needed, or kind of just the quantity of patients that came in during the pandemic?
So I think that's a complicated question. I think it certainly did have an impact. As hospitals and elective procedures were shut down and capacity was limited, there's a subset of the population, particularly uninsured, that doesn't have access to screening care. And so we often see them in the ER when their condition is advanced. And I think that what little access they might otherwise have had was taken away. And so I think that subset of the population was particularly more susceptible to having conditions more advanced at the time they were detected. And that's something that you can argue whether that's the role of the emergency department, but it is certainly something that we see all the time. It's a lot easier to get follow-up for a patient that you see a mass on, for instance, on chest x-ray, than it is to get screening for someone that doesn't necessarily have any signs of cancer. And so I think that's something that those people weren't coming to the ER during that time, and I think that there's been a period of time where many people's conditions progressed, and maybe they were discovered later in the disease course than they otherwise would have been.
So on that note, how do you think that the Lubbock community can kind of better prepare to respond to future kind of large-scale health challenges? Maybe not necessarily a pandemic, but kind of any other similar.
I do think that this was very good at helping us understand how to mobilize our surge capacity, because certainly the pandemic caused an extreme increase in demand. But there are many other conditions, shootings, large accidents, multi-casualty incidents that could also cause us to have a surge in demand. And I think this pandemic took that out of the realm of drill and put it into actuality. We actually had to figure out, are we going to use the SIM Center to provide patient care? Are we going to keep patients in PACU? How can we rearrange our ICUs and our inpatient beds to handle this increase? One of the other things is that it sort of loosened some long-standing rules that were somewhat silly. I think, for instance, from the emergency department, we were never able to discharge people with oxygen before.
Right.
And as a result of COVID, now we can discharge people with oxygen because we sort of acknowledge that we can't put everyone in the hospital that needs just a couple of liters of oxygen.
Right.
Whereas before, there's a lot of bureaucracy, and Medicare wouldn't recognize it unless it came from a PCP, and so there were some hurdles to that have since been removed. And I think in many ways the pandemic sort of forced people to just find solutions. And I think that kind of mindset is beneficial for the healthcare system.
So in a sense, it kind of tightened up the rules and kind of made them more efficient by kind of like a trial of fire.
Yeah, it kind of said, we acknowledged how precious inpatient rooms are. And there's a lot of things that the standard of care for the emergency department is a little bit different than that of an office-based practice, for instance.
Right.
And so there are certain things that if they come to the ER, even if the likelihood is somewhat low, the standard is that we admit, or we hospitalize, or we do this procedure, etc. And when we just didn't have that capacity, we were allowed to be a little bit more flexible. And I think that is probably a net benefit to the system as far as improved efficiency.
So for our last question, if you had anything else you'd like to share regarding how the Lubbock community responded and was affected that you didn't share prior, or just any kind of thoughts that you had while we had this interview,
Sure.
feel free to go ahead.
Yeah, I would say I really do think that we were very fortunate in Lubbock. I do think the leadership of the hospitals and the public health community was very proactive. The CEO of UMC sent out an email every day with what percent inpatients COVID we had, how many employees were out. They were very aggressive in reassuring the healthcare staff that they were not going to be abandoned. And so they, for instance, if someone was exposed or tested positive for COVID, they were given 2 weeks of essentially time off without having to use their vacation or sick pay or something along those lines. And I think that was a important message that the administration understands what the staff is going through and are very supportive. I think we're very fortunate in that regard. From an emergency standpoint, many ERs across the country cut their staffing as patient volumes fell, and we did not. And I think that's again a testament to the support that the administration has for this ER, because they wanted us to remain open and to be prepared for any contingency that might arise. And I'm very grateful that we practice in such a community.
Thank you so much for all your thoughts. That was very eye-opening on especially the pandemic experience for the Lubbock community. If you could tell us your name and position one more time.
Sure.
As we close out the interview.
My name is Trey Morris, and I'm an emergency physician at Texas Tech UMC.